When you came in, you'll see there's two tables on the left-hand side. They have literature, which you're very welcome to take, information about if you've had stomach operation, information about GIST generally, and it's one of the new one that's got food and stomach written on the front of it is a new one that we've designed. It's an amalgamation of two others, making it a bit easier to read. So please help yourself to those. There's also some T-shirts. I don't think we're modelling any. We've got a different coloured one, but they're white. We don't sell anything. We're not allowed to as a charity, but we do accept donations. So anything that you'd like, there's these wristbands, there's the pin badges, anything like that, help yourselves to. There's some donation boxes. We'd be really grateful. I was about to say that we are up to the 22nd century technology in that we have credit card machines that Kathy will be able to do. So, you know, if your donation runs into the thousands, it's not a problem. You know, we can take that as well. So please, as I say, help yourself to anything on there. I don't know about trying shirts on. I don't know if you've got a private place to do that, but anyway, it's all there for you. Right, I haven't said hello. Good morning. And you? Thank you very much for coming. And I will hand this over to you. You'll need this, won't he? Yeah.
Hi, thank you very much. Okay, absolutely. Okay, just check so it goes. Okay. Oh, okay. Over here. Hi, nice to meet you all. My name is Larne. I'm a general surgery resident and research fellow at the Royal Marsden. And I really wanted to talk to you today about this trial that we want to do, and we think it's a really exciting trial, and I think we need to do it. And this is why I wanted to talk to you, to get your thoughts, which is the most important thing, and feedback, and how we could potentially make things easier for patients to have this sort of method of surgery, and also what your thoughts are about it more broadly. So it revolves around helping surgeons see tumours more clearly using a special dye called ICG. I'm the research fellow on the trial, and my boss, Mr. Miles Smith, is the principal investigator on the trial. And it revolves around something that they're doing, originated up in Newcastle, using this dye to remove tumours, sarcomas in the arms and legs. So I'll talk to you about who it's for. It's primarily for GIST patients mainly, but also patients with sarcomas in their abdomen. What we're doing, what we're comparing it against, and what we want to measure. And the most important part is I want to get your thoughts on it. So you'll all know more about GISTs than I will. But obviously they're rare tumours that grow in the digestive tract. They're a type of sarcoma, which is a type of cancer of connective tissue. And many of you will know that for localized disease, surgery can be the main treatment. And the goal of surgery is to remove all of the tumour with none of it left behind. And sometimes some tumour edges are left behind, and they can be hard to see during the operation, as I was mentioning. So even with all the imaging tools that we have available at the moment, with CT, MRI, often there can be some tumour which is left behind. So what they started doing in Newcastle about 5 years ago is they started using this dye called ICG, which I'll talk to you about a bit more, in the arms and legs, sarcomas in the arms and legs. And they found that their rate of leaving the tumour behind was much lower in patients that they'd used this dye for compared to patients which didn't have the dye. Some centres can be up to 10 to 20% of operations can leave some tumour behind. GIST can often be hard to see because the abdomen is a lot more, things tend to occasionally look quite similar in the abdomen. If it's left behind, it's called a positive margin. And we believe there's a way that we can help surgeons see more clearly, which is using the dye. And the most important thing is that patients with GIST and abdominal sarcomas have an unmet need, I believe, because they're excluded from the sarcocyte trial. So that's why we want to include them in our trial. So this is what a GIST can look like. That's kind of a small to medium-sized GIST. As you can see, it's growing out from that's a loop of bowel. It's growing out from a loop of bowel. ICG is a fluorescent dye that was developed during the Second World War as a photographic dye, and it began being tested in humans in the 1950s. And initially in medicine, it started being used for perfusion scanning, most notably in the eyes. And recently, it's become standard practice in lots of different types of surgery, where you might be removing a bit of bowel and then joining it together to give this dye to assess blood flow in the bowel. So anyone that's having any type of operation, most notably for colorectal cancer, but also for bariatric surgery, removing a stomach, a lot of patients that have had GIST removed may have had this dye as well if they had some of their bowel removed and then joined together. And it's given during the operation to see how well the blood is flowing to the bit of bowel which has just been joined. Because obviously, if you've got good blood flow, that's a good sign. But if you've not got good blood flow, then you might need to change the way that joint has been joined. The thing that we want to do, which is different to what's been done before, is we want to give this dye 12 to 24 hours before the operation. And this is because this is what they're doing in the sarcocyte trial. And there is what happens in the tumor from lab work that's been done is that as the cancer develops, it develops its blood vessels very well, but it doesn't develop its drainage system as well. So what happens is you can give the dye, it'll go into the blood circulation system, and it will get washed out of all the healthy tissue, and it will be remaining in the cancerous tissue. This is called the EPR effect. It means the tumor glows under a special camera which can help the surgeon see the edges of the tumor. As I mentioned, it's been used in Newcastle for over 5 years, and they found that only 5% of patients had some cancer inadvertently left behind with the ICG compared to around 25% without it. And there's early evidence from other tumor types that also shows this method works. The ICG can highlight tumors in the brain, liver, and lungs. And as I mentioned, abdominal sarcomas and GISTs are not included in the sarcocyte trial. This would be the first, our trial FOCASS, would be the first trial to test this specifically for GISTs and abdominal sarcomas. And often GISTs can have highly vascular tumors, which would make them a good candidate for a sort of intervention like this. It's also worth noting that they've also found in early studies coming out of the US, this method of giving the ICG a day before surgery was used in pulmonary sarcoma metastases. And they successfully identified 90% of all of the metastases that they saw on the CT scan before the operation. And they identified an additional 15, I think it was 15 metastases, which weren't seen on the CT scan. So metastases is when a cancer spreads from its original site to another site in the body, essentially. And for sarcomas, it's most likely to be the lung. But what was quite interesting about this trial is that they actually identified a number of GIST metastases with the ICG. So I think this shows that you can use this to not only identify sarcomas, but identify GISTs. Because as I will mention, this has been used to try and identify GISTs, but they were giving it during the operation. So a study in the Netherlands tested ICG in 10 GIST patients in 2022, and I think Kali-Swaat, the first author was called Kali-Swaat, and they gave the dye during the operation, and they looked 5 to 15 minutes later to see if they could see the tumour glow. And they'd found that there was no difference between the tumour and the surrounding tissue. And what we're postulating is that they didn't allow enough time to let this dye reach the tumour because of that abnormal blood vessels and drainage system that can develop in cancers, as I was saying. So what we want to do is give it 12 to 24 hours before the operation. And as I mentioned, what they're doing in Newcastle and what's now has been rolling out into a national trial called the sarcocyte trial, which will also be opening at the Marsden soon, shows that sarcomas do accumulate this dye after this delayed fashion. So we're not repeating what's been done, we're trying a different method. So this is what the image can look like when you use the infrared camera. These are just two different settings on the camera. So you can see it glow in green like this, or you can use a different overlay and you can see more of a vasculature, the way it's distributed. And this is the camera we're going to be using. So this is a camera that's made by Stryker. It's a near-infrared camera, and it has settings to see this specific dye called ICG, but also the standard laparoscopic stacks and robotic stacks also have near-infrared cameras on them. But this camera would be just for open surgery, but our trial is going to include patients that have open surgery and both laparoscopic and robotic surgery. Okay. So what are we comparing it against? So this is just a feasibility trial, so we only want a very small number of patients initially. And we just want to ask the question of whether you can use this to see the tumor under the camera, and there's not going to be a comparator group. However, if we see that you can use this to identify GIST during the operation, then we will push for a much larger trial where we have normal surgery with just normal light, and then this group that had the fluorescence-guided surgery. So if patients that are coming for this trial, their surgery is not so the idea is it's not meant to change the surgery, but we are going to be monitoring if that does happen during the operation. The only addition is going to be the dye preoperatively and the use of the special camera during the operation. We want adults over the age of 18 with a confirmed GIST or abdominal sarcoma planned for surgical resection, and both open and keyhole surgery can be recruited for the trial. And this is the part which we're looking to see how we can facilitate is they must be able to come into the hospital 12 to 24 hours before surgery for the dye injection. So it would mean arriving the day before your operation. So what we're measuring is we just want to measure whether it glows. So we're just going to be taking the pictures and looking at the glow in the cancer and then comparing that to the glow of the surrounding tissue. Similar trials to this have called this the tumor to background ratio. And what's generally accepted is if it's 1.5 times greater glow in the tumor than there is in the healthy tissue. And we would also, a separate kind of sub-study would be that we want to record the operation as well. And we're going to send the specimen to the lab to see if they can find any ICG which is present in the tumor tissue. And we're going to have a form that the surgeon will complete during the operation to note whether it did impact their decision-making at all. And also, we're going to report the number of cases where there was positive margins, so some tumor was still left behind, but that's just for reporting, because obviously there's not enough. This trial wouldn't be recruiting enough patients to have this as a primary measure. And we'll consider it a success if we have greater than 70% of tumors which are glowing during the operation. So as I mentioned, the next step would be, if this was successful, to design a much larger multi-hospital randomized controlled trial which would compare this type of surgery to normal surgery to remove GISTs. And with as part of the sub-study, which is going to be a separate consent form, we would look to see if we could develop like an AI-assisted tool to predict the margins based on video footage. And in the US as well, there's currently a children's hospital which is running a trial where they're giving this dye to any child with a solid organ tumor. So because it's shown that it can be used in this delayed manner if you give it 24 hours before the operation for lots of different tumors now. So this is something potentially down the line, but I personally would like to try and do this at the Marsden, but I think we need to prove that it works in GIST and abdominal sarcomas first. But basically, I really want your feedback on this because it would help develop the trial, and it would help us refine, how we can help patients get involved with this. So we have a page on the Cancer BRC Patient Voice platform, which I can send Kathy the link to, but that's the web address there. And you're able to give feedback on the trial on that web page. So I would really encourage you to do so, please, as well as the discussion today. And we want patients to be involved from the design to running of the trial to trial monitoring groups. And your feedback today will directly influence how we run the trial. So questions I'd like to get your thoughts on are, how would you feel about coming to hospital the day before the operation? What barriers do you think patients would have in terms of whether they wouldn't want to come? And how would you feel about the operation being recorded for research purposes? And what information specifically would you want to know? And what are your thoughts about this surgery more broadly? And I would just mention, because I realised there's one thing which I had on the slides, which I forgot to mention, the anaphylaxis rate for using ICG is 2.4 per 100,000. Could we go out to that slide? Is that right? It's anaphylaxis is a life-threatening reaction to a drug. And in ICG, it's 2.4 per 100,000. So that's less than penicillin, which is 10 to 20 per 100,000 patients that have the drug. So in terms of reaction, just before opening the discussion, I was just saying it's a very safe and well-tolerated drug. But yeah, just wanted to mention that. So please, if you can go back to the discussion section. Thanks. So yeah, any Nick, any thoughts or?
Yeah, so open up to the floor now. We've got a hand up, so I'll go to Tony in a minute. My view, for what it's worth, yes. Yeah. I mean, if I was in that situation, none of that would worry me at all, because if it meant that it was a better outcome at resecting the gist with very little risk, then for me that would be a no-brainer.
Yeah.
But everybody's different. So if you could put your hands up for asking a question, I'll come to you with this microphone because it's got to go on YouTube.
Hi, Larne. Thanks for that.
Thank you.
I've got two questions, actually. The first one is, so if this is a dye which, from what you say, has the ability not only to detect margin around the tumour, but also potentially mets as well, metastases as well, why do we use PET scans? So why are we using, radioactive dye, which obviously for children is difficult? Why aren't we using this instead?
So the ICG dye has a penetration depth of about 2.5 centimeters. So if you're looking at it with a camera, you can see it 2.5 centimeters from the depth. So obviously you can't take a picture of someone's body from the outside and see this dye at all, because it would be buried. You'd have to get very close to it to see it. That's why PET scans used.
Okay, and you mentioned particularly around abdomen. So are there any areas of the body where this wouldn't work for GIST? So for instance, stomach. I mean, I'm assuming you can use it for stomach. tumour?
Yeah, you could use it. I think you could use it for stomach tumours. I think the key thing is, as I mentioned, it's around a 2.5 centimetre penetration depth of the dye if you get the optimal glow. So a tumour which was coming from inside the stomach would be harder to see, but GISTs arise from a connective tissue, so closer to the outer layer of the stomach. So you should be able to see a GIST in the stomach with the dye.
What are the chances of GIST cells circulating in the bloodstream or the lymphatic system and making surgery of limited benefit?
Well, it's an interesting question, and I think a lot of times when we do surgery, sometimes we don't know if a GIST has already begun to spread. I don't think that's a reason to not do surgery. And do you mean the effect of the dye if it picks it up if there's GIST cells in the bloodstream and the dye is picking it up in the bloodstream? No, it wouldn't pick it up in the bloodstream. But I agree in what you're saying. If there's already GIST cells spreading, maybe we shouldn't be doing surgery. But unfortunately, we can only go off of what we see on scans before the operation. But what I think we could see in this is we could detect occult mets elsewhere in the abdomen, which potentially haven't been picked up on a CT scan. So I think that's another reason to do this trial, because that would influence the post-operative in terms of the medical oncology side of things, what they would want to be doing. If we know we actually detected an additional met in the liver, we saw it with the ICG dye, I think that would influence their decision as well after the operation.
Hi.
Hi.
The ICG, what is its actual mechanism of action? Does it actually just show a concentration of blood flow? Does it stick to anything?
So there's been the guys up in Newcastle, they've been looking at how ICG actually, the mechanism of how it enters sarcoma cells. And for the most part, it doesn't actually enter the cell. What it is the collection around the cell with the tiny blood vessels that it develops. And because it doesn't develop a good drainage system as the cancer progresses, it's left sticking around the tumor. So it's not that it's going inside the cell necessarily, but it's just being collected in and around the cancer basically. Whereas in healthy tissue, it's got good lymphatic drainage, so it's got a good drainage system to wash away the ICG. So it would have all left the healthy tissue while staying in the tissue which is cancerous.
Is there anyone who shouldn't have this dye?
Yeah, so if you've had a reaction to ICG in the past, then obviously we don't want to recruit these patients. But also there is one thing the sarcocyte trial are doing, and I think it's more from a theoretical point of view, is if you've got certain thyroid disorders, our plan is to not recruit people with certain thyroid disorders, because there's a theoretical risk that it's a similar compound to thyroid hormone, so it could exacerbate thyroid disorders. So our plan is to not recruit these patients for this trial. But I think as we progress more, we should be able to get rid of that, because in standard practice up and down the country in colorectal surgery, that is not a reason to not give this dye. So I think it's more for monitoring purposes than a true sort of you cannot have this dye contraindication.
Yeah, can I just clarify? You are asking, are you patients who are coming into a situation where they're having an operation, a removal or resectomy, okay, to come to the Marsden Is that correct? In other words, are you then looking at cooperation with other GIST specialist hospitals and other oncology centres where instead of them, for argument's sake, going into Queen Elizabeth Birmingham or into Cheltenham or wherever it may be, instead they're coming in fact to you?
So for this initial trial, it's just 15. We're going to recruit a very small number of patients. It is just going to be at the Royal Marsden. But if we show that we can identify GISTs with this dye, we would then look to collaborate with other centres, and then they would open it up. Ideally, they would open it in their hospital. Yeah.
Just going back to the question on is anybody not suitable for it? I'm making an assumption here, but presumably you do a full analysis of the person prior to them making any journey or trip to you. Yeah.
So the other thing that a lot of GIST cancer patients will have experienced with the dye will have been the CT scan. And one of the things that's a bit of an issue with CT scans being given regularly to GIST cancer patients is that it can affect your kidneys. So how is that dye? It's not anaphylactically high rate of risk, but is the dye which is there around the tissues, even though it might have been removed in the tumour, is it easily removed from the rest of the body quickly, or does it take a long time to it be removed?
It is excreted by the kidneys, and if you've got impaired, if your kidneys aren't working properly, it will take longer to exit the body, but there's no evidence that that's harmful in any way.
This might sound totally ridiculous, sorry. Do you have to be a patient of a specialist centre? Because the oncologist sits on the board of a specialist centre. However, the pancreatic surgeon, because the GIST is in the pancreas, is not a GIST specialist, and it would be done in a local area. How would a patient in that situation be?
So if this trial is successful, and then we look to do a multi-center trial, then I would imagine we would ideally want good coverage across the country with centers that were involved in this. It would depend. Yeah, it would depend whether this trial was opened at the hospital that you were being treated at. If this is not just the way we're structuring this is GISTs. The majority of patients recruited to this trial are going to be GIST patients, but we are recruiting patients with abdominal sarcomas as well. So it's not just necessarily a GIST specialist, but it's more if they do abdominal sarcomas at your centre.
The advice is always to be looked at a specialist centre. You have the right to ask for that as well. Yeah. You can also always contact this trial will be it will be up on the Clinical Trials Network website when it's up and running, and you'll be able to contact a centre that's got the trial open.
Some GISTs are deemed inoperable because of their location or whatever it may be. Do you think if this is successful, it'll open up the possibility of operating on some of those GISTs and removing them?
I don't think so, because there's multiple reasons why we wouldn't operate on someone that had multiple sites of GISTs, and this is more looking at whether we can get a better shot at getting it out during an initial operation, rather than seeing if we can go in where we wouldn't usually be going in surgically for metastatic disease.
Yep. I have a question. Hi. It's a broader question about the surgery. If this does progress and the dye is given before surgery, having looked at the photographs that you showed us that showed the dye, it seemed to me that it was very unclear where it ended. It was quite fuzzy. So I would assume that you would err on the side of safety and cut out everything you can possibly see where there is any dye, which would presumably mean that you'd be cutting out more than might have been cut out if the dye hadn't been used.
Yes, so that's what we want to measure, is whether, if this does impact the operation and the surgeon's decision during the operation, if they go back and they do take more than they were planning to, that's something we want to measure, and that's something that the sarcocyte trial is measuring as well. Also, part of the fuzziness, let me just go back if this is working. That's all right. The slide with the images, the pictures of the... so it does look a bit fuzzy on this one, and actually what contributes to that is the quality of the camera that you're using as well, and some of the laparoscopic and robotic cameras aren't quite as advanced as the open cameras that we use. So to an extent, some of this will be determined by the camera, and it may be that we would see that the better camera you have, the better image you get, basically.
Any more questions from... I'm just going to go there first, if you don't mind, because you've already spoken.
How might the findings impact on the long-term follow-up and treatment plan?
So for this, just undo my laces. For this trial, it's not going to impact on the follow-up whatsoever. If we were going to do a trial where a much bigger trial where we're comparing it to normal surgery, we would want to follow patients up for 5 years, which I know is usually the standard follow-up for a GIST anyway, but we would probably want to do it a bit more regularly, and see patients as part of the trial team, seeing them for 5 years, but it wouldn't change your follow-up in any meaningful way.
Hi. A lot of GISTs are discovered accidentally during operations, as mine was. So I went into the operation with the surgeons expecting it to be a GIST from my ovary, not a GIST, a tumour arising from the ovary. And then they found out that it was arising from the ileum, and that they didn't know then, but it was likely to be something more like a GIST. So in that case, I would not have been, even now, have been given the dye 24 hours in advance, because they weren't expecting it to be a GIST. So going forward, if this works, would they have anybody coming in with a tumour, GIST or not, would they do that as a precaution? And then if they did find out that it was a GIST, what would happen? Because there are a large number of GIST tumours removed that were never expected to be GISTs.
Yeah, I agree with what you're saying, and this is something that we're probably not quite there yet, but there is what I really would love to do is a trial where you're just giving this dye to any patient that has a solid organ tumour in their abdomen, getting surgery to see how well you could see the tumour with it. But yeah, I think we should. That's something I want to do. I don't know how. It would probably take a long time to get set up and get it running. But that is what I agree with you. That's the sort of thing we should be progressing towards.
Oh, just as I thought that was it.
Real quick one. What are your timeframes?
So we're applying for the Sarcoma UK grant in September, and we would look to get the trial set up probably July to September next year. That's probably the time frame, yeah. And the trial, when it's set up, the trial will run for 1 year. So from July, September 2027 to July, September 2028.
Okay. Right, I think we've asked all our questions. That's great. We're going to post the link on the website and put it in the newsletter.
And
Yeah.
I would just say, sorry, I don't know if my email's in there, but if anyone wants to email me any feedback or anything at all, please just email me. I think it might be at the end. Is it the end? You've got it anyway.
We'll post that
That's
as well.
perfect.
Yeah,
Thank
we'll
you,
post the
Kathy.
email.
Thank you.
Can you go back to the picture of the camera as well a second? There's two things I wanted to say. First is you mentioned Scandinavian trial. I think
Dutch trial, yeah.
Dutch trial. Not about the Dutch trial, just that's an example of international collaboration. And almost every trial that goes on, you'll talk about this worldwide, probably.
Yeah, the results, yeah. We will, yeah.
And we are dealing with a company called Cogent in America for a trial on a drug that they've now just had accepted in America. They've supported us in the UK, Just Cancer UK. They go to all of these meetings that I go to as well, and it's an example of how they've used our patients as well. We've given them access through the proper GDPR channels so that patients can be involved in trials that they're doing in America remotely from here. And it for me, it really does show that this is an international community working together.
Yeah, absolutely.
And the final thing I wanted to say is Stryker. Anybody recognise that name? Used to be a Formula One team. It's amazing, isn't it? The international engineering that goes in across the world, and that's used to be a Formula One team.
Yep.
So, can we show our appreciation to Larne for